Good morning, everyone. My name is Caoimhe Gleeson and I'm from the HSE National Office for Human Rights and Equality Policy. I'm delighted to welcome you to the fifth and final session in our autumn webinar series From Policy to Practice, Consent, Assisted Decision Making and Tools for Practice. Today's session will focus on tools to support decision-making capacity and what works in practice. The impetus for today's session came from many queries from frontline practitioners at the early stages of the pandemic who asked for practical guidance in how to support a person's decision-making capacity, especially in contexts where family members, friends, circles of support were restricted due to infection prevention and control measures. These issues remain pertinent today. So we have an excellent panel of speakers and experts who have hands-on experience of supporting decision-making in many diverse contexts. In particular, our chair today is Professor Sean O'Keefe, who brings a wealth of experience of advocating for the least intrusive interventions with people who need support with decisions and for ensuring that the person is always kept at the centre of decision-making. We have just under 800 people signed up for today's webinar, so welcome to all of you from every corner of Ireland, from those that are coming from outside of the HSE and indeed those from other jurisdictions. We've been delighted with the support for these webinars for the last, since June actually, since we started doing these webinars. This webinar series is being organised by our office and by the National Quality Improvement Team. Our office is leading the preparation of the HSE for the commencement of the Assisted Decision-Making Capacity Act and for the oversight of the National Consent Policy, which includes the Do Not Attempt Resuscitation Policy. We also have responsibility for a number of other human rights and equality policy issues. We've held a number of these webinars since September, indeed since June. The details will be in the chat box of our website and where you can access those. If there are specific related topics or issues you'd like us to address in our January, in our kind of spring session, please let us know. Get in touch with either Jacqueline or Orla, and their details will be in the chat box. Equally, if you have specific expertise you'd like to share in this area, please get in contact with us and we can collaborate with you. The chat box is open. That's the box on your right-hand side. We'll try and help with your technical issues throughout this function. Jacqueline, Orla and Elaine are here to support you with this, and I'll just go through some of those technical issues just now. Please post your technical questions in the chat box to all panelists. You'll see there's a little scroll down button. Don't just direct it to the host, because Jacqueline will not be able to get to all of those queries, just to spread the load. Don't worry about muting. You're automatically on mute, so you don't have to worry about that. If you want to change your view so you can see all panelists, you go to the top right-hand corner of the video screen and it'll give you another number of options that you can click on. And we'd advise that you use the grid view so you'll be able to see all panelists during the panel discussion. If you're having issues with sound or internet connectivity, we'd suggest that you dial into the webinar, and the dial-in details are also in the chat box. Sometimes the sound may be clearer, particularly if you're in an area where the connectivity isn't great, or you're in a hospital in particular may have difficulties because of barriers and stuff to sound. Please post your questions during the webinar into the chat box to all panelists, not just the host, so that the panelists are able to see that as well. If we're unable to answer all of your questions in the webinar, we're developing an FAQ document, which we've been developing since the start of this series. This will be emailed to you and it'll be available on our webpage. The webinar is being recorded and it'll be made available on assistedDecisionMaking.ie next week. Please share this link with colleagues who are unable to make it today. In terms of CPD, we've been awarded CPD points from the RCPI. We've 2 points from them, and CEU points, 3 points from the Nursing and Midwifery Board. Tomorrow or Monday, you'll receive an email with your certificate of attendance and details of how to apply for your CPD points. If for those of you from Corru, the Law Society, the Bar Council and the Dental Council of Ireland, you can use your certificate as proof of attendance for your CPD record. Please note that CPD and NMBI points will be rewarded to those attending the live event. This is a stipulation from those regulators and accrediting bodies. The webinar today will finish at 12:40. So I'd now like to hand you over to Dr. Philip Crowley, who is the National Director of the National Quality Improvement Team, and he's also acting National Co-Lead on the public health response to COVID-19 to open this morning's session. We're delighted that Philip is able to join us for today's session and indeed has been a great supporter of this work since we started. So thank you, Philip.
Thank you, Caoimhe, and really delighted to be involved again in what is the final webinar of a series of webinars on consent-assisted decision-making, and particularly the practical nature of today's session I think is really valuable. I'd like to commend the National Office of Human Rights and Equality Policy, which is part of my overall team, Caroline, Caoimhe, Jacqueline, Orla, and Elaine today, and others who work with you. The work is really, really important, and I think sometimes when you work in quality improvement and you're working around quality, you can kind of work to develop the best, highest quality services. But if you don't attend to the issues of equity and equality and equity of access, you can have the best services in the world, but they're no use whatsoever to people who can't access them. So I think the emphasis on equality, and particularly today on human rights, I think is really important, because I think also we all know we can improve practice, particularly in the area of promoting people's rights in very vulnerable situations when we're delivering care, to make sure that they are at the core of decision making, that their rights are respected, and that their decisions prevail wherever possible. So I think today will be a very good session in terms of, we have a great panel of experts. Caroline, Professor Mccarron, Seamus Moran, and Joanne Condon will I think run a session that will really help inform us, and with your participation using the chat box, we'll hopefully enhance all of our practice in relation to ensuring that we really respect people's rights and their participation in decision making capacity. This is the fifth event of what's been a really wonderful series of webinars, I have to say. Over 4,000 people since September have attended these webinars, which I think shows all of our commitment to doing things better and to really working around the areas of consent and capacity, and ensuring that people's capacity is maximised and that they participate in the decisions that affect them, that are most important to them, let's face it. We will continue with the new series of webinars, hopefully in spring of next year. Who knows where we'll be at that stage, but things are looking good overall in relation to the pandemic at the moment. So hopefully we'll be able to run those webinars in the new year. This, I think, will be. I think the importance today is that the audience is very, very expert as well. So we really do want you to participate, share your experiences through the chat function, and then that better informs the work that we do as well to support you in your work, which is all we really want to do. I'd like to really thank all of our panelists, a really excellent group of people who are willing to give up their time to share with us today their experience and their expertise. And I'd like to particularly thank our chair, Sean O'Keefe, who I've known for a very long time. He's a consultant geriatrician in the University Hospital Galway, and also co-chairs our National Consent Advisory Group and a member of our National ADM Steering Group, which are all voluntary additional commitments he takes on top of a very, very busy workload. So we really appreciate his expertise, his partnership with us in all of this work, and his support. So thank you very much, Sean. And with that, I'd like to hand you over to Sean to run the rest of the morning. Thank you all very much.
Thank you very much, Philip, and thank you everybody for joining us. These webinars all occur in the context of the ADM Capacity 2015, which isn't yet commenced, but it's important to note that it's ADM with capacity in brackets, not the other way around. And it's easy to get focused on capacity assessments as the main issue, and it's the wrong way. The most important is supporting people to make their own decisions, and that's very much the focus of what we're going to talk about today. So I'm delighted to get the meeting running. Tools to support decision-making capacity, what works in practice. And our first speaker is Caroline Howard, who's the Speech and Language Therapy Manager in St Michael's House in Dublin, which is a service for people with intellectual disability. And Caroline's a Trinity graduate and subsequently with a Master's from UCD in Disability and Rehabilitation Studies. And she's a member of CORA's Appeals Committee and is the HSCP representative on the HSE National Consent Policy Advisory Group. So thank you very much, Caroline.
I hope. Hopefully everybody can see that okay. Okay, great. Thank you very much, Sean. Good morning, everybody. I'm delighted to be here this morning to talk to you about practical tools to support decision making. As Sean explained, I'm a speech and language therapist manager in St Michael's House in Dublin, which is a service for people with disabilities. This morning, I'm hoping to touch on each of the topics outlined below. To be honest, anyone who knows me knows that I'm pretty passionate about this topic, about communication and decision making, and there's probably a danger that I could talk for at least a month about it all, but don't worry, I won't. I'm going to try to focus on the core messages on each of my slides, and where there's more detail outlined, I know the office will make these presentations available after the event for people who want a bit more detail, or for those perhaps who are joining by phone. So when I started to prepare this presentation, the first thing I thought about was, what does it really mean to support decision making? And I went back to Gerard Quinn's writings from NUIG and found myself refreshing some of the foundation principles of rights-based person-centred decision-making, and thinking about how supported decision-making means balancing independence versus interdependence. It means expanding civil rights to make them effective, not limiting them. It means providing supports that build capacity, that truly promote the centrality of will and preference, that assist a person to make choices and decisions, and enable people to understand what's going on and express themselves in a way of their choosing. Supporting decision-making means providing supports that are person-centred, local, and community-based. Undoubtedly, for a lot of the people attending this webinar this morning, I'm presuming we're all working to support decision-making across a range of life's scenarios. For us in our service, we often try to differentiate between decisions that are important to the person and decisions that are important for the person, and then act in line with the person's will and preference accordingly. For me, definitely over the years, I have found the value is to be found in supporting a person to make their own decision, regardless of my perception of how complex or important the decision appears to be. I've learned that it's not for me to decide what decisions are important to a person, and therefore in my work, the basic premise tends to be the same. I work to support people to make their own decision whenever and however possible, ensuring people have the experience of making decisions, thereby developing their own confidence and competence to do so. I suppose the worry would be that for some people, particularly people with complex communication needs, they're not always getting that experience, even in day-to-day life. So do they have the opportunity to decide what they're having for dinner or what socks they're going to wear today? And if we're not exposing people and supporting people to make those decisions in a fair and transparent way, how can they be expected to meaningfully contribute to decisions that are more life-changing? Going back to Gerard again, he does remind us that how we support people to be involved in and make their own decisions will evolve, as our own experience and confidence in doing this evolves too. He also says that the supports and the tools that we use to support decision-making should look outwards. That is, they shouldn't just be focused on the skills and abilities of the person themselves. And I'm hoping many of the tools I touch on today will aim to explain more about that. So this presentation is focused on practical tools to support decision-making, with a focus on those supports particularly needed for people with communication difficulties. Sometimes implementation of practical tools in the reality of working in health and social care settings can be challenging. They might be limited by staff availability, time pressures, access to certain disciplines, a global pandemic. However, this first set of tools is very much within each of our own control, because person-centred decision-making must start with my own beliefs and values. So when I start with these tools to support someone to make a person-centred decision, I have to begin with my own belief that the person does have the capacity to make their own decision, unless and until the contrary is shown. If I don't have that very essence, if I don't have that fundamental belief, then chances are this decision-making process is going to be flawed. I must have an ability to observe the person's will and preference. And that ability can be pretty tricky, depending on how the person communicates, but I must be committed to try to uncover the person's will and preference. I must have an intention to really understand the specific decision that has to be made and to be committed to understand the implications of that outcome of that decision for the person. Related to that, I must be willing to spend time to understand, is this a decision that's important to the person, or is it more of a decision that's important for the person? I should be able to reflect on my influence over the timeline for making the decision. And that can be hugely variable, depending on the type of decision that has to be made or the setting that you're working in. But I should be able to try to advocate for more time if it's needed, wherever possible. Particularly for people with complex communication needs, time can be a real factor. I should be able to coordinate who's getting involved, and I must be assertive in identifying that only those in the person's agreed circle of support should be getting involved. And I should have a knowledge of people's right to receive information in a way they understand, and I should have a commitment to upholding that right. So, the reality. For me, are all my beliefs and values always in check? Tick, tick, tick. Or does it sometimes get a bit more complicated than that? Acknowledging our own beliefs, biases, perceptions, past experiences, and what that might bring to a situation is a really valid and important step when we're supporting someone with a communication difficulty or disability to make their own decision. During the pandemic, it could be said that some of those beliefs and values have sometimes been more challenging to fully implement, or maybe it's that some situations have become more complex. And although we're on a webinar, maybe it's something people can try to do later on or at another stage, but take some time to reflect and think about how has it been challenging, or has it been challenging for you as a healthcare worker to support person-centred decision-making during the pandemic? Has it been challenging, more challenging than usual in your service? Is there space for you or your service to acknowledge these challenges? And if there are challenges, what tools do we need to do something about it? Having a coherent framework is a helpful tool in trying to ensure a consistent and transparent approach to ethical person-centred decision-making. On the slide now, and I know some people are by phone, but maybe you can see it later, but there is a framework we wrote in our service to support decision-making, particularly during the pandemic, when the pressure to make complex decisions in really short timeframes was escalating. Now, this wasn't a paper exercise. We weren't aiming for more admin and paperwork for people, because nobody wants that. But it was viewed more as a tool that people could use, staff could use, to talk through the types of decisions that were trying to be made, and to think through key factors that must still be paramount to make sure the person is still at the centre of the decision-making process, even in the midst of COVID pressures. We don't have time to talk through the complete ethical framework today, but it will be there on the slides for people who want to look at it afterwards. We used the framework, or we continue to use the framework, to support us to make some quite complex decisions over the past number of months. And we hope it can continue to be of use into the future. For example, we use it to support decisions around how to best support service users who have to self-isolate for reasons associated with COVID. We used it to make decisions around how to manage requests for visits by St. Michael's House residents to family homes, and visits to St. Michael's House residents by other family members. We've used it to talk about how to best support service users who've had limited or no access to traditional day services since the beginning of the year, and how to balance the will and preference of one individual in a house with the will and preferences of all those they live with. We've also used it to decide whether exceptions to restrictions needed to be explored, and if so, under what circumstances. A person's communication strengths and needs will influence their ability to contribute to decision-making processes. This is because communication difficulties can make it more difficult for people to understand, think, and talk, or communicate about decisions. Having an understanding of how communication influences decisions is essential for anyone involved in supporting decision-making. It isn't enough to say, he couldn't tell me he doesn't speak, or she didn't understand that, it's too complicated for her. Communication processes are complex and they certainly aren't black and white. Having even a basic sense of why communication breakdown is occurring is the first step in ensuring how to better present information to a person in a way they understand. So, for example, a breakdown could be happening at the level of auditory memory. Maybe the person has difficulty retaining information provided verbally in the short or longer term. Maybe they have difficulties with visual memory, retaining visually presented information. Perhaps the breakdown is happening in the person's symbolic understanding, and this is the person's ability to understand visual information. So perhaps they understand colour photographs, but not black and white photos. Maybe they understand symbols, but not printed words. The breakdown could be happening in the person's language comprehension. Do they understand the basic concepts of what's being considered? Do they understand the load of information in each sentence? When we're discussing decisions to be made, we often use complex grammar structures like if, because, probably. Do they understand the choices that are being put before them? It's possible the person has strengths in comprehension, but what about their expressive communication skills? Have they access to the right communication system for them? How do they communicate expressively? Do they use verbal language or other means? If they do communicate verbally, do they have access to the right vocabulary to express their opinions around the topic? Are they able to form sentences to discuss options and ask questions? And finally, but not finitely, because we could talk about this for a long time, perhaps the person has got strengths in both understanding and expressing themselves, but what about their social or pragmatic skills? How much experience does the person really have in making decisions and in communicating their opinions? Are they comfortable expressing their thoughts in an assertive way? And have they got the opportunity to do so? People with communication difficulties must be supported to make decisions, to demonstrate their strengths and abilities and express their wishes and preferences. An accurate understanding of a person's communication strengths and needs directly relates to our estimate of a person's ability or their capacity to make a decision in their lives. The RCSLT, the Royal College of Speech and Language Therapists, made quite a powerful statement on this topic in 2018. They say that mental capacity assessors, as it's called in the UK, who are not able to identify and support individual communication needs effectively may make inaccurate judgments about a person's mental capacity. People who are erroneously judged to lack capacity will be denied the opportunity to make autonomous decisions. People who are erroneously judged to have capacity may not fully understand the implications and consequences of the decisions they are asked to make. People's health and quality of life may be affected negatively if they are not fully supported to participate in decisions about their care and treatment. So, if you have toolboxes 1, 2, and 3, your beliefs and values, your framework, and a basic understanding of the theory of communication, now you meet someone with complex communication needs, and a decision needs to be made. How are you going to support them to be included in the important decision-making processes in their lives? Many people on the webinar this morning have possibly already heard of inclusive communication, but if you haven't, inclusive communication is an approach to communication that enables as many people as possible to be included in that interaction. It recognizes that all human beings use many ways of understanding and expressing themselves. It encourages, supports, and enables people to use whatever ways of understanding and expressing themselves which they find easiest. The truth is, we all communicate in many different ways. I don't communicate in only one way. I know I'm finding this webinar this morning very restrictive to only be able to speak to a screen. We all have lots of different ways of communicating. We might speak verbally, use body language, pictures, writing, sign, objects of reference, switches, and devices. The important thing is that all methods of communication are valid and all are equally important. It's important to acknowledge that facilitating inclusive communication isn't something that everyone can do perfectly at the drop of a hat. It's a complex skill and it does take time. But there are things that all of us can do to promote better communication within decision making, and that's still within our control. We all need to look at today and next week what is within our control in supporting people with complex communication needs to participate in decision making, and make the most of whatever time is available to you with that person. Learn about the person's communication profile. What are their everyday comprehension skills and what supports increase their understanding? If you add photos, pictures, laws, sign language, does it help? Do they communicate verbally? And if they do, is it single words they use, or phrases, or sentences? Or non-verbally, do they communicate using vocalizations, body movements, body language? It's all communication and it's all valid. What is the person's preferred ways of communicating? And do they use alternative ways of communicating? Really listen to what the person is communicating to you, regardless of how they are communicating that information. You can find some of this information out by asking the person themselves. It's always the best place to start. Talk to someone who knows the person well and ask them for information about their communication profile. If the person has a communication passport or a hospital passport, please read it or ask if they have one. I'll talk more about those just in a minute and show you an example, but they're a short, concise, succinct way of finding out key information about a person's communication preferences. Speak to a frontline staff member or clinician from the person's service and ask them for input. Refer to speech and language therapy if you think it's required and if it's available. And obviously all of this with the person's consent. You might remember at the start of the presentation, we talked about supports, not just looking at the person's own skill set, but looking outwards as well. That means for us, we need to think about, as communication partners, how we are facilitating the conversation to be had. Start by looking at the environment where you're going to discuss this decision with the person. What's it like in terms of space, light, layout? Is there a lot of background noise? Are there visual supports available to the person to enable them to engage? Can you link in with the person's use of routines? Is it better to have this conversation at the start of the day, the end of the day, after a meal, when they've had a nap? Think about people who play key roles in the person's lives and how can they be involved in facilitating the discussion, if appropriate. And lastly, but not of least important, think about ourselves. Communication, as we know, is a two-way process. What are you like as a communication partner? And how can you be a supportive communication partner in this process? Make it easier for the person to pay attention. Say their name first, get their attention, reduce distractions. Make listening easier, say less. And that's really, really hard. Often we want to say more to help people understand better. But for people with complex communication needs, that can be really overloading. So try to say less and use simplified language. Make it visual, show them pictures, photos, objects, and make it multimodal. Like we said, nobody communicates in just one way, so combine different approaches, combine gestures, visuals, body language. Above all, give the time that you've got. Look for more time if you can. Go slow. Some people need more than 10 seconds to process and respond to verbal information, and that tends to be in relation to normal everyday routines, not new abstract information about making a potentially very important decision. I'm going to finish up by showing you some examples of everyday life resources and tools that we tend to use in our service to support people to be involved in their decisions. I mentioned communication passports earlier to describe how a person communicates and how others should communicate with them. Please try to find out if the person you're supporting has a passport. They are short. They are not lengthy to read. They're not like lengthy big reports. They're a short summary of a person's key communication information and can be a super shortcut to get to know whether you're on the right page with this person or not. Here's an example of one, a fake one, obviously, that we tend to show staff in our service to help them to develop individualized ones about adults in St. Michael's House. We also use accessible information to support decision-making. Accessible information for those who are information to support decision-making. Information, new to the term, means giving people meaningful information in a way they can understand. The important thing to know is that accessible information can look really, really different for different people. On your left-hand side of your screen, there's an example of an object and visual timetable to help someone understand what's happening in their day. The next symbols are the easy read COVID signs that we're using around our headquarters in St. Michael's House to help people understand COVID rules. And the last is an easy read letter to support someone who has to go to hospital to understand the process that's ahead of them, and to hopefully engage with their experience a little bit better. We also use talking mats quite a lot, and these can be really helpful to find out what a person thinks about a topic. So the aim is to facilitate a topic of discussion using pictures on a mat, and the person is shown a series of pictures where they might express what's important to them or what's not important to them, or perhaps around something that they like or something that they don't like. When you start using talking mats for the first time, we tend to just use them around quite a basic topic to begin with, just to introduce the idea of talking mats to the person. Thanks, Marie, I'm just finished. So this is an example of a gentleman who began just by talking about his preferred TV programs, just to introduce the idea of the talking mat. You can see on the left programs he does like, and on the right programs he does not. And then we moved on to the clinical scenario. So this person used the talking mats to make decisions around his speech and language therapy goals. So on the left, he identified elements of his communication profile that he was content with. And on the right-hand side were those parts of his communication that he decided were not okay for him, and he wanted to work on more to improve his experiences out in work, and out socializing with his peers. The last slide now is just an example of an individual with intellectual disability who needed support around their decision to use a medical device. This person was prescribed a medical device to be used every night following discharge from hospital, but they found it very difficult to use it, and their staff could not find any accessible information to explain to the person the rationale as to why they needed to use the device. The staff member thought about the person's current profile, communication profile, and then they created a document to support the person to understand why they needed to use the medical device, how to use it, and what the benefits were of using it. The service user was supported with these new materials, presented in a language they understood, and with visuals to successfully use the device. The person was able to make the decision to persist with the device and learn how to understand and use it. So, in conclusion, what we've tried to cover this morning is that I know I can support decision-making by checking in on my beliefs and values, by applying an ethical framework, by understanding how communication influences a person's ability to make decisions, and by using tips and resources that support inclusive communication. Thank you.
Thank you very much, Caroline. That's a real tour de force of practical advice, enormously helpful. We'll come back to the questions at the end, but I think we'll keep going with the panel. And first of all, on the panel, I'm delighted to introduce Mary Mccarron, who will talk next on practical steps to support people with decision making. And Mary is a real international star in the fields of intellectual disability and ageing and dementia and palliative care. And she's Professor of Ageing and Intellectual Disability in Trinity and a former Dean of the Faculty of Health Sciences indeed. She's a principal investigator and founder for IDS Tilda, looking at longitudinal ageing in persons with intellectual disability, and has led a massive longitudinal course study in dementia with Down syndrome for many years. She's a key advisor nationally and internationally on ageing and policy issues related to this, and in 2019 was the recipient of the inaugural HRB Impact Award for her extensive research in these topics. So Mary, without further ado, thank you very much for joining us today.
Thank you, Helen. I'm going to attempt to share my slide. I'll have a short slide presentation, okay? Can you see that?
We can indeed. Thanks, Mary.
Thank you very much. Okay, I get to see it myself, so waiting for it to come through. Okay, thank you very much, Sean. And I'm going to share with you some of our experiences and guide you perhaps to some other materials. And thank you, Caroline, for an outstanding presentation. As Sean has mentioned, I'm the director of the first dedicated centre at Trinity to investigate key issues on ageing, known as the Trinity Centre for Ageing and Intellectual Disability. And this has been very much underpinned by the Intellectual Disability Supplement, the Longitudinal Study on Ageing, IDS TILDA, and very much the centre is focusing on world-leading research and scholarship. But we have, this is here the IDS TILDA story. And the reason I'm showing you this particular slide is to talk to you about our involvement with people with intellectual disability now in this study for 14 years. And when we started this study back in 2007, many people told me that I was crazy, that a study of this nature would never work, it was too complex. We've had a 95% retention rate over 14 years. And that didn't happen by accident. That happened because at the very beginning of this study, we had a very critical values framework that underpinned it. And that values framework was one around the involvement of people with intellectual disability from the beginning to help us to understand how best to run a study of this nature. The developments, as Caroline said, of easy read materials and of accessibility and making reasonable accommodations to a very hefty protocol that was coming from the general study in ageing to make sure people could participate. And the main aims of it was to understand the health characteristics of ageing in people with ID, to examine the service needs and healthcare utilisation, to identify the disparities in health status of people ageing, compare that to the TILDA findings yielded for the general population, and to support evidence-based informed practices and evaluation. And from the beginning, as I said, we had a very strong values framework that underpinned that, and that was around the inclusion and choice of people with intellectual disability. And I really owe a huge amount of debt to people with intellectual disability for their encouragement and support of this study over many years. And I'm not, you know, this information in relation to the UN Convention as well as I do, a very experienced panel, as Shauna said at the beginning. But just taking some of the articles, and I just want to talk a little bit about the data from IDS TILDA to give meaning to this. Article 19 around living independently and being included in the community. That people should have the opportunity to choose their place of residence and where and whom they live with on an equal basis with others. And you can read that in the slides later on. In IDS TILDA, over the first 3 waves, that was over a 10-year period, we can see what choice looks like. And as Caroline has spoken about, it's really important that people are involved in simple choices, in the everyday choices, because then they're able to make big choices. Choices around what you eat, what clothes you wear, time you go to bed, how you spend money, and if you work and what job you work at. And as you can see, over the 10 years, choice did increase in a number of areas, but particularly around day-to-day activities of living. But we still have a long way to go in relation to choice in some areas, particularly in things like where you live or who you live with. So we've seen improvements in some, but not for everything. So we have still ground to make up there. In relation to choice about other important issues, something like money, 24% choose how to spend the money, 56% were supported in their choices of how to spend it, 19% had no choice or choice was made on their behalf about their money, or where they kept their money. 17% reported that they chose where they kept their money, but 47% reported that they had no choice and that this was made on their behalf. So we all understand how critically and empowering having control or understanding your own finances is to both self-worth and a meaning of self. So the Assisted Decision-Making Capacity Act will provide more formal support, as we all know, to help people make decisions. But as and Caroline alluded to this, decision-making is a muscle. And we must understand whether people have the opportunity to make choices every day if we expect them to make big life choices. And this is really important. Who do you confide in relation to trust and safeguarding? From IDS TILDA, we've shown that most people with intellectual disability in our study, and this was a nationally population-based study, About 80% of people confide it in their key worker. Some people confide it in siblings and friends, with the next two highest. In relation to access to advocacy services, 51% said they had an independent advocate, and 70% said that they had, 72% that they had access to independent advocacy services, which is to be welcomed. The UN also talks about the right to choose, the right to freedom to express opinion, accessible formats, use of sign language, accessible information formats. And Caroline spoke at length about this, and this is just so critical and important. Certainly during the COVID crisis, I had numerous conversations with people and requests for supports around particularly end-of-life planning. And as I just want to say, it's really important that people have been empowered to make small choices in their life. My concern is going out and asking people how they want to die with an intellectual disability when they have never been asked in the first place how they want to live their life. That is a very large transition, and there's a huge ethic and moral responsibility on all of us to make sure this doesn't happen. We work with the All-Ireland Institute of Hospice and Palliative Care, and this is a pack of decision-making tools which may be helpful to services, and they can be downloaded and they're for free on our website. And it is really accessible planning tools, and Professor Ailish Burke, a colleague of mine, was very involved in the design and the work on this particular package of tools. And this really was around facilitating end-of-life discussion with people with intellectual disability, and helping them to record their end-of-life wishes and preferences. So there is a guide that you can use to help you engage in those decisions, and a guide about the tool itself. And that will be all available to you to look at afterwards. So this is, again, we know we have the healthcare passport, but this is just gives you an example of what's included. You know, the person's name, the photograph, their carer, and if they were sick, or how much information would they like to know. If the doctor had to tell you bad news, who would you like to be with you? A photograph of the person. Where would you like to be cared for? So there's a whole series of very simple questions that you can work with the individual to help understand what their wishes and preferences are, should they be ill. And it is best to do this at a time when there's not a crisis, because very often decisions are made and they're charged by high emotion, because we leave these end-of-life decisions too late and people are not afforded the opportunity. And then it's a very stressful period for the person themselves, very often, for their family, their loved ones, and indeed for staff caregivers. So I would say try to avoid emotionally charged decision making and make this in time. And that just gives you some more information on what the tool looks like. So it really is around helping, prompting the person to think about the future and what they would like, talking to people they trust about the issues, writing down what they want, and revisiting it whenever they wish, so that the person has this and they can hold on to it. But the issue is, and the guide for carers, very often carers need a guide to how do I start this conversation. So we need to use these opportunities, not just when somebody themselves perhaps is sick, but around everyday life. Perhaps when a family member or friends die. Sometimes we tend to shield people with an intellectual disability from those conversations because we feel that it's too distressing for them. We often don't allow people maybe to attend funerals or to be with their family member, their loved one, when they're dying, because we're trying to protect them. But that isn't good for the individual very often, nor more than it is for any of the rest of us. And we need to build capacity for individuals in dealing with life events. So we need to look at all incidental opportunities that may arrive. When there's a death maybe on TV, it's a good opportunity to start a conversation, or when the person is dying. And remember, as Caroline said, to use simple, concrete languages. And the care conversation very much builds on knowledge. It works with the person's capacity. It connects to other people's conversations, and it provides support to the person at difficult times. So using this with Caroline's ethical framework that she has that she has outlined, I think hopefully may be helpful to people who are supporting people on the front line. But we know that there are a number of barriers often to these care conversations. And as I said, often misguided by the desire to overprotect. We want to maybe think we are preventing distress. Too difficult for bearer of bad news. Bearer of bad news lacks the knowledge of the illness, so the person themselves just may not feel competent about it. Or there's a lack of a sense of time. And none of these conversations happen as a once-off conversation. Caroline spoke about that. We must drip feed this information. We must do it very sensitively, constantly checking in how much the person is retaining, the readiness for more information, what they understand already. And this all takes time. And oftentimes, of course, there can be conflicting views with stakeholders in terms of the information somebody is able and should receive. This is also another accessible planning tool in terms of future planning to assist families. And this also has been developed by Dr. Darren McCausland and Professor Damien Brennan at the Centre. And it is around a future roadmap. Again, a guidance document and an accessible planning tool. And again, helping to support the conversation about future care and making the interview process accessible, understanding what constitutes accessible information. And I think Caroline has spoken at length about that for the participant, and what is their preferred communication method, and also using accessible language that has been checked by people with ID, focusing on the present and making the future relatable. And that's really important. So when we talk about focusing on the present, framing the conversation in what is already understood by the individual, the future as a concept can be very abstract for many people. And as I said, making the future relatable, using simple phrases such as when you're a bit older or in a few hours, can make it more relatable to people. And managing sensitive topics. And this is really important to understand how we support these conversations about future care, and understand that some of these discussions about future care by necessity also includes difficult topics, such as the death perhaps of a parent or primary carer. And we need to be prepared ourselves as to how we will engage and deal with those issues, and how our ability to give emotional support, highlighting to individuals that there may be a need for emotional support and identifying where that support can be reached. So as we begin to build back better, there is an opportunity now, and it is critical that people with disabilities are part and parcel of the response which countries are preparing. And I think these responses, well designed, can address the inclusion and discrimination faced by persons with disabilities, thus creating more resilient communities and systems. And many of you may be familiar with the United Nations Disability Inclusive Response to COVID-19. Thank you very much.
Thank you very much indeed, Mary. I'm going to remember that phrase, that it's hard to ask somebody how they'd like to die when you've never asked them how they want to live. I think I'll steal that for the future. Thank you, everybody. And I'm going to move straight on, and we'll come to the questions, as I said at the end. The next speaker is Seamus Moran. And Seamus is principal social worker in Mayo for almost 20 years at this stage, and one of the hospital leads in patient and family engagement, and a former member of the management team. Like myself, he's toiled long and hard on local placement forms, which is a very difficult role, and is also an ISCP accredited counsellor and a master trainer in stress control. So very much at the cutting edge in a difficult role in acute settings. He's going to talk about the role of advocacy in supporting people to make decisions in acute settings. Seamus. Seamus, you're mute.
Yeah, Sean.
There you go. Yes, indeed.
Thank you. Thank you very much, Sean, and thanks to Mary and Caroline. They're hard acts to follow. As you say, I am a principal medical social worker in Mayo University Hospital in Castlebar. And the hospital deals with everything from birth to death every day. And I work with patient experience advisors. We have a program here in Mayo University Hospital that is based on a Canadian model from Kingston Hospital in Canada, where we have patients and families who have had an experience of the hospital service in the last 5 years, who come and work with us to bring their real lived experience of the hospital service to us as the health professionals. And that has been an extraordinary experience for us in the hospital, to hear people who've had experience of our care in the hospital in the previous years and maybe ongoing. And one of the things that struck me, and one of the messages that came from the patient and family experience advisors, was how incredible an environment an acute hospital is. And while I would have had some appreciation working 20 years in acute hospital of that it's an extraordinary environment, the patient experience advisors got me to look at and got my colleagues to look again what it's like for patients when they come through the threshold of an acute hospital. An environment that's 24/7, 365 days a year, an environment that deals with life and death every day, an environment that has its own language, baselines, ADLs, dysphagia, and that this environment can be very intimidating and frightening for patients. And even for patients who are very powerful in their own lives, who are very educated and articulate, some of those patient experience advisors would say when they crossed that threshold and became a patient, some of their power as a human being or autonomy was diminished just by the environment itself. And I thought that was a very powerful message, because those of us who work in acute hospital every day can take that for granted. And as one of the patient experience advisors, as she said herself, she was a frequent flyer into the hospital with a chronic condition. She said that when she came into the hospital, there was the danger for her to lose her voice, that she could become invisible and not be able to articulate her wishes and needs. From a medical social work point of view, I've always believed that the importance of the relationship is central in trying to ascertain what are the wishes and preferences of the patients that we're working with. And again, because it's such a challenging environment to build that relationship and have that communication, when you go on to a busy medical ward where you have 6-bedded units, where there's all the activity going on of a daily hospital, it's very difficult to get the time, the space, and the environment to have a meaningful communication with the patient. However, it's absolutely essential for that to happen. And again, I suppose from a social work point of view and from my psychotherapy point of view, I think the important tool is the ability to build the relationship with the patient, and particularly with the patient who could be frightened, who may have conditions that makes it difficult for them to communicate. There could be somebody post-stroke or some serious operation. However, the importance of being able to meet with the person and to establish that relationship and that trust and rapport. And again, our patient and family experience advisors would say to us, if they feel the person truly is interested in them and is actively listening to them, and is also showing kindness and compassion, that this can make such a difference in them being able to find their voice, to be able to say exactly what it is that they want in relation to their medical treatment, but also in relation to their discharge and other significant life challenges that may be facing them. They may have to consider long-term care, which again is a very big decision, a monumental decision for a person to have to make. So again, I would always say to my colleagues in social work and on my team, the importance of building the relationship and building that rapport and trust. And it can be done, again, to the basics of making sure that we introduce ourselves. My name is, very simply, again, to introduce what our role is, because sometimes we may, in our busyness, forget to introduce exactly why we're here to see the patient. Also, they're very important that the patient consents to seeing us. Again, sometimes professions are rolled in to see the patient and the patient don't know we're coming. And secondly, they haven't consented to that. So I always get, when I'm working with patients and clients, I always check, have they consented to seeing me? And I think that gives a message to patients that there's a choice here. And again, I think in relation to advocacy and enhancing people's decision-making, it's important to stress that people do have choice, as basic as the choice whether to engage with whatever profession is in front of them. So I think, again, that is important. I suppose I think of a number of cases that I've worked with, and I chose not to do PowerPoint presentation, but rather to talk a little bit about some of the people I've worked with. And those people at the time had given me permission to share my learning. When I came into the hospital first, almost 20 years ago, I was asked to see a 98-year-old woman who the team felt was shouldn't go home, that she was too frail, that she had lived by herself up until that point in time. And I asked the nurses, I mean, did she have family? And they said, oh yes, she has a daughter in her mid-60s. And I thought, should I ring her first and just check? And then I thought, no, why should I do that? And I checked, is the woman compos mentis? And they said, oh, absolutely. So I went up to the bedside and I introduced myself and I said, you know, would she be open to talking to me? And I said, could I sit down? And she said to me, Mr. Moran, you're the first person in the 3 weeks that I've been in this hospital that has asked, could I sit down? Does that mean you're going to listen to me? And I said, I hope so. And she said, there are kids at the bottom of my bed in white coats, and some of the medical team almost 20 years ago were in white coats, telling me what to do. And she said, I'll be damned if somebody tells me what to do. And again, it was very clear that this woman had her own very strong opinions and had every right to express those, and she was determined to go home. And I suppose that opened the discussion for me and her about those wishes and the pros and cons in that. But again, it was that piece of her feeling that she was being listened to, I think, was important in that interaction. And she did go home. And again, I suppose she taught me the importance of the person themselves being given the right. 98, deemed to be frail, but not frail in mind, and was ultimately be able to go home to live for a number of years independently with support. Again, in our role as medical social work and working alongside the multidisciplinary team, OTs, physios, speech and language therapists, all of us have a role as advocates, particularly for the frail, for those who may have lost their voice, be that psychologically or physically. And so again, the importance of trying to understand the person's life. Because again, many patients say to us, I'm much more than the cancer diagnosis. I'm much more than the stroke. And the importance of trying to understand the person in the context of their lives, I think, is important. And I think, again, that in an acute hospital, sometimes we can just concentrate on the illness. And that's the importance of trying to get a history from the patients they're able to give it, try and get a history from those who know them, their families. Now, a number of the speakers previously talked about the challenges of the pandemic. And certainly that is a challenge for us now in the acute hospital system, that we don't have as free an access to those important people in our patients' lives to build maybe the bigger picture. But it is still possible to build that bigger picture, whether that's by phone contact, WhatsApp contact with families. And certainly here in Mayo University Hospital during the first round of COVID, a lot of my workers were working on the COVID ward with people who were seriously ill, who were facilitating FaceTime discussion with their families. And in that sense, that it was a support to the patient, but was also helping them with their stress levels, because again, as a psychotherapist, when we're anxious and stressed, it's very difficult for us to be able to make clear decisions or good decisions. We're sometimes in that fight, flight, freeze mode. And it's important, I think, when we're working, whether we're OT, speech and language, nurse, doctor, that if we're sitting in front of a person and they are stressed, that we, first of all, acknowledge that, and then that we try to decrease that stress. And that can be, again, in our tone of voice, again, in emphasizing that the person can talk to us in their own time, and that if this isn't the appropriate time, that we can come back again at a more appropriate time when the patient is feeling better. And again, I think if patients, and this is what our patient experience advisors are telling us, that if they feel that they're being listened to, that there is a compassionate and kindness in the interaction, that makes such a difference in them being able to articulate their wishes. And it can be as basic as that. But sometimes in the busyness of an acute hospital, and I'm sure in other settings, the listeners out there, that we can forget how stressed and anxious a person can be. So using some of the more gentle techniques of being able to deal with stress and help our patients deal with stress can be a very important tool in empowering them. The other thing that came up when I was preparing for today in relation to advocacy in the acute hospital, again, if the patient is deemed to be frail or elderly or has an acquired brain injury, sometimes the system within the hospital can lead to the person being disempowered, or this person cannot go home. They're too high a risk. We have a duty of care to ensure that they're safe. However, the important piece in this is, again, to go back to the patient, that person-centered reality, as it were. And again, as best we can, to try and explain the risks that people perceive, whether that's the professional teams or whether that's family or our community colleagues, and for the person to make a decision as to whether they want to live at that level of risk. And at times, it can be very difficult, I find, as a practitioner and also like as a leader of the team, where family are saying, under no circumstances can my uncle go home. My uncle will be found at the bottom of the stairs and ye and this hospital will be responsible for that. Or like you'll have professionals outside saying, under no circumstances can she go home. She lives in appalling conditions and you cannot let this person go. And again, I can understand those concerns, and they are very real. However, this is about the patient's life, and this is about the patient's right to autonomy and self-determination. And if that patient is saying that they want to go home and manage that risk or live with that risk, they have every right to do so. Something about the acute hospital system or even the health system can be very paternalistic, maternalistic, where we then almost see, oh, the patient is frail or has an intellectual disability or has acquired brain injury. We have to make those decisions for them, and absolutely not. The patient, the person, that's the first place or person that we go to, and we build out from there in relation to family and others who may be involved in their lives. But to get their view as to what they want to do and what risks they need to take. Again, I would say that the National Consent Policy is essential that we are all aware of the National Consent Policy, because sometimes in this benign paternalistic, maternalistic view, we start making, again, decisions that legally we are not, we don't have a mandate to have, that the person has capacity and thus the right rests with them, the legal right. Also sometimes, and I'll finish on this, that some of the teams, professional teams, can give too much power to families in relation to making decisions. Again, under the National Consent Policy, it is either the patient, the person, who makes the decision, and if they lack capacity, then in the medical setting, it will be the consultant decide, not the family that's signing DNRs or other making crucial decisions about their welfare. And in my 20 years working here in an acute hospital, these are some of the advocacy challenges that I face daily, weekly. The other piece, and the final piece, the importance of working as a multidisciplinary team with our OTs, physios, doctors, nurses. Everyone has a piece of jigsaw, but ultimately the biggest piece of the jigsaw rests with the patient and those that knows them best, usually family, and also in this partnership teamwork, working with the likes of SAGE and advocacy services from physical disability. It should be a partnership approach to enhance people's capacity and ultimately to allow people to self-determination as to what they wish to do in relation to their lives, their illness, and their future well-being. So thank you.
Seamus, can I just check that you can hear me? My microphone hasn't been working terribly well.
I can hear you, Sean, yes.
Great. Thank you very much. And every word of that rang true to me as somebody else who works in the acute system. And I think some of these issues we'll come back to because they're related, aren't they? Particularly the issue around where someone lives that Mary also alluded to. But we'll come back to that in a while. But I want to go to our last panel member and introduce Joanne Condon. And Joanne is a regional manager with the National Advocacy Service for People with Disabilities, the NAS, since 2014. And her background is a degree in social work and a master's in community work from UCC. And Joanne has a particular interest in advocacy, practice and policy, and has dealt a lot with very complex cases, including wardship and violations, issues of abuse and related to consent and capacity. And Joanne is going to talk about ascertaining will and preference in people who need support with decisions. Joanne, thank you.
Thanks very much, Sean. So I'm going to look, as Sean said, at the topic of ascertaining will and preference with people who need support with decision making. And I'm going to be focusing particularly on those who cannot articulate their will and preference verbally. And this will be particularly relevant under the ADM Act when a decision making representative is appointed, particularly as they're bound under the Act to give effect to a person's will and preference. It seems each time I'm on this webinar, it doesn't like cooperating with me moving slides along. So bear with me a second while I see if I can get this to work. Unfortunate. Oh, there we go. Okay. So the UNCRPD says that supported decision-making model recognises that all people have the right to make decisions and choices about their own lives. But it's important, of course, to recognise that this isn't something that's always been recognised, and context in this regard is very, very important to mention at the outset. There's a long, long legacy over many, many years of oppressive behaviour and paternalistic attitudes that have stigmatised people with disabilities and led to best interest decision-making and substituted decision-making. There's also been a prevalent historical view that people who do not communicate verbally are unable to express their preferences in relation to decisions about their lives. And traditionally then, decision-making has been characterised by a set of individual cognitive abilities, including problem-solving, memory, language, and rationality. But an approach like that fails to recognise the interdependent nature of the lives of people with others. And the UNCRPD situates disability within a social model framework and mandates that people must have the support that they require to exercise their legal capacity. So in this way, the CRPD drives the shift away from protection towards support and social inclusion by searching for ways to enable the voice of the person. So I think you'll agree that every human being communicates, and 70% of all communication, of course, is non-verbal. So no matter how will and preference is to be understood, recognition and respect for a person's will and preference depends hugely on the social actions of others. Jo Watson highlights that a supporter's willingness to see a person beyond their disability is found to impact their responsiveness to the expressions of preference by those they support. And Caroline touched on this earlier when she mentioned the supportive communication partner. And there's been a number of Australian studies by the likes of Markova, Dobson and others that have shown that change occurs when supporters possess attitudes and expectations that people will interact and will communicate. It's true then to say that supporter responsiveness is key to supporting people to articulate their will and preference. And Article 12 embodies this relational conception of personal autonomy and supports the idea that the qualities of the supporter and the person's relational setting matters. So the question that we arrive at then is not, does the person have the capacity to communicate their will and preference, but rather, do we have the capacity to establish the person's will and preference? On a previous webinar, I outlined how when a person is not in a position to articulate their will and preference, advocates use 4 internationally recognised approaches to ascertain the person's will and preference. Now, rather than explaining those approaches again, what I'm going to do is illustrate their use through a case example of a piece of advocacy work that was carried out by the National Advocacy Service. So I'm going to tell you about Sue's story. Sue is a person in her 20s with autism spectrum disorder who had been living in a large residential setting for over a decade until the service closed and she was moved to an emergency placement in a rented house with support staff from a care agency. The staff had no training or experience in supporting people with ASD, and the team had limited input from multidisciplinary team with expertise in ASD. All of this led to a restrictive service being provided to Sue. Many of the doors in the house were locked, furniture in the house was minimal and bolted down. The person spent most of their time in one room and was accompanied by 2 staff at all times. Sue would engage in a behaviour where she would collect items and store them in a box. Staff would then remove these items on health and safety grounds, and Sue's behaviour was generally viewed as difficult by those working with her. Sue only left the house for drives or when she would go to her parents' house for short visits. As far as Sue's parents were concerned, Sue was safe and protected in her home, and they were too elderly for her to live with them. They were happy for staff to do whatever they saw fit to keep her safe. Sue had no other family members to advocate on her behalf. So an inquiry was received by the Advocacy Service and work began to try and establish Sue's will and preference. I'm going to give you a flavour through the use of these 4 approaches as to what the advocate was able to determine about Sue's will and preference. So using a person-centred approach, which really is about building up a picture of Sue's lifestyle, her preferences and her needs. The advocate spoke to a number of people in the person's life and read information and reports that could help paint a picture of who Sue was. It was important in doing this to come to the table with a healthy degree of cynicism, to identify where assumptions might be made and not to take information at face value, and always asking the question, is Sue being empowered or disempowered in these descriptions and in her experience? Staff spoke very negatively of Sue to the advocate and spoke about her being bold and saw her behaviours as controlling and attention-seeking. Staff spoke about how despite trying varied activities, Sue would just not engage in them. Sue's parents were able to provide a number of insights into who Sue was, outlining her life story, her likes and dislikes, such as her love of flowers, her love of fragrances, and were able to identify the reasons for Sue not engaging in the activities offered was because the activities were of no interest to her. Her mother identified that Sue was a girly girl and enjoyed activities of that nature, which were not on offer. Sue's mother also described how when Sue would visit home at weekends, Sue would often try to remove the furniture from the home and take it back to her own house with her. A piece of information that was intriguing in light of the sparseness of the house that she lived in. The advocate read information, files and reports. The information contained in files did not capture who Sue was. Much of the information contained negative discourse about her problematic behaviour. In addition, an occupational therapy report on file further compounded the negative narrative with a number of restrictive measures recommended to manage Sue's behaviour within the house. Whilst the written information shed little light on who Sue was, it certainly shed light on the fact that no assessment of her needs had been carried out, and the support that was being provided was without knowing what Sue's real support needs were. It confirmed her needs were poorly understood and poorly met. Using the witness observer approach, the advocate spent a lot of time with Sue. The advocate observed the person over time and documented what they observed and what they learned. The advocate noted the presence of 2 staff with Sue all of the time, the many locked rooms, the sparseness of her home with little furnishing, no homeliness, no activities, no structure. Her house was located in an isolated and rural setting. The advocate started to notice more about Sue's communication style. An example was that Sue was observed to tap her chest and vocalise in a particular way when she would meet certain people. Over time, and through questioning, this exploration and repetitive action that was noted led to a discovery that Sue had in fact at an earlier point in her life used love to communicate. And what she was doing was indicating, using her love sign language, the expression that she liked certain people by tapping her chest with the love sign like. Sue could also clearly indicate her unhappiness with people by pushing them away or walking away from them. Accountability in this work was key in order to ensure that at no time was the advocate imposing their own interpretation on things without sufficient evidence and triangulation of information to do so. Human rights-based approach was used to recognise Sue as a rights holder, and the advocate examined information that they collected to identify if any of Sue's rights, to see if Sue's rights were being respected, protected and fulfilled. Significant rights issues of restrictive practices in Sue's environments were identified: locked doors, removal of items. In addition, chemical restraint was identified, with the regular use of PRRN medication to manage behaviour with no clear diagnosis and no exhaustion of least restrictive alternatives. The advocate then made representations to seek a review of Sue's medication. And additionally, the advocate made representation on Sue's behalf for an assessment of her need and for appropriate supports to be put in place. Finally, using the ordinary life principles and looking at what an ordinary life might look like for somebody in their 20s and examining Sue's life under the 8 domains of quality of life, it quickly became apparent under these 8 domains that with regard to skills and abilities, they had not been identified or promoted. In relation to community presence, it was non-existent. In terms of continuity, There was no sense of Sue's past or Sue's future, only the here and now. Her choice and influence was minimal. Her individuality was really unrecognised. She had minimal status and respect because the focus was on risk management and safety. Her relationships were minimal, and there were significant issues in relation to well-being with regard to sleep, medication, diet, and health issues. There were multiple quality of life issues that the advocate used to raise questions of decision makers. This information was also used and the quality of life domains later on in terms of her onward placement and transition planning, to ask questions to see if these areas of her life could make for the best possible quality of life. This case example illustrates the significant role of the supporter. I won't outline in detail the significant transformation that it brought about for the person. It's set out on the slides. Sue went on to move to a new service that was far less restrictive, that focused on her support, on her ability and supported her. She learned to shower and dress independently. And some of her will and preference around her love of fragrances, for example, was an enabler in supporting that capacity to be built. She learned how to make breakfast with minimal supports, engage in the community, go shopping, and many other more meaningful activities. Sorry, I'm having some issues moving my slideshow on again. There we go. So I'm not going to get into the detail of the transformation that came about. You can read this on the slides that will be made available afterwards. But suffice to say that support to responsiveness was a key enabler for the person to have choice and influence over the decisions that were being made about their life, and to have their will and preference kept at the centre of the decision-making process. As demonstrated throughout this case example, meeting with the person over time was key to understand who they are, how they communicate, and in identifying their will and preference. Without meeting the person in this example, the information provided by third parties would have given little insight into Sue's will and preference. Decision-making representatives are bound under the ADM Capacity Act to give effect to the person's will and preference in the decisions that are being made. However, there is nothing in the Act that requires the decision-making representative to meet the person, and nothing that sets out the frequency of the meetings that should occur. Seamus mentioned in his talk about the importance of relationship and trust and rapport to decision-making. And this omission from the Act is a concern in that regard, and hopefully perhaps an issue that could be addressed within the codes. As I come to a close, it's a big topic to cover in such a short space of time, but I hope the illustration I've provided today has offered some insight into how will and preference can be identified for those who require support to do so, and what a transformational impact it can have for a person when our supporter is responsive. Thank you.
Thank you very much. I hope you can see me as well as hear me. I seem to be having trouble with my video. Anyway, thank you so much, Joanne. That's a really wonderful case study as to how we can do it better. I'm going to move on to questions. We've quite a few of them, and there are certain recurrent issues there. And I'll start maybe with one for you, Caroline, and it was about building capacity. And the question was saying, to what extent is speech and language therapy input always needed, or to what extent should these lessons be known by the broader MDT community? Would you care to take that one?
Yeah, sure. Yeah. Can you hear me?
I can.
Great. Yeah, I saw that question pop up. I suppose there's two layers of that for me. At an organizational level, or whatever setting people work in, I think it's worthwhile thinking about what kind of policy you have to promote communication for everybody. So on our service for the last few years, we've worked to develop a total communication or inclusive communication policy. And what that means is it's part of our organization's mission statement, our values, that all staff recognize the various forms of communication. So all staff are invited to receive training on that from the speech and language therapy department. But then it's expected that those people who work with the individuals on a day-to-day basis then follow through in supporting the person to communicate in the way of their choosing. So I suppose while speech and language therapists definitely have a unique role in advising and certainly, providing support in complex situations, communication is really everybody's business. And I think oftentimes it's the people who know the person best, who work with them on a day-to-day basis, are intimately familiar with their communication profile and therefore have to contribute in terms of, providing supports in a decision-making process.
Great, thank you, Caroline. Recurrent questions about wardship and the current system. And now our whole webinar is based on preparing for ADM coming in. But maybe it's been mentioned in terms of where to live, and that was mentioned both by Seamus in terms of the practical difficulties we sometimes face in acute hospitals, and also by Mary. And maybe I'd start with you, Mary, and say you've no doubt been looking at the AC case and the implications and the issues about deprivation of liberty. Have you any comments about where you think we should be going or what your hopes are with the new legislation? Mary? Mary, you're on mute.
Sorry. Yeah, can you hear me?
I can.
Yeah, great. Okay, thank you, Shania. Well, I mean, I think I just told Shauna light really on how non-involved people with intellectual disability were really in terms of those important decisions of where they live and who they live with. And yes, I think this is like from my perspective, I think this is fundamental and key for all of us. So I think I think there definitely needs to be. I think your question was, where do I see this going? Is it, Sean? Yeah.
Yeah.
Yeah. Well, certainly, I think we have to make a real effort to using an ethical and moral framework and using the act to engage in those conversations with people and to have some plan around that. Because what I often find happens is, particularly in ID services, when people are at the most vulnerable in their lives, perhaps when they have a dementia, and it's not often because the dementia is that bad, it's because often the group home loses the capacity to continue to give what people would say care with comfort or with safety, and the person is just moved out. And the person, it's not that they move, they lose everything. They lose the people that they're familiar with, they lose their sense of community, they lose their friends, they lose everything. And we've got to really have a concentration on if the will and preference of the person is to stay there, how do we really make it happen? And that's for everyone in our society.
I'll ask you the same question, Seamus, because from the acute hospital, you've mentioned it extensively as the problems we face. Do you think we're too risk averse? How are we going to fix that in practical terms?
Yes, I think again, we talk about duty of care. Can you hear me, Sean?
I can indeed.
Yeah, again, there can be an emphasis of duty of care and of trying to minimize risk. But again, ultimately, it goes back to the person, and particularly in relation to in the acute hospital, where you're working with adults who may have capacity but deal to be frail. And ultimately, my message, to myself and to others like me is that the person, be they 45 or 95, has the right to manage their risk. They're the risk managers ultimately. It's not the social worker or the consultant. And sometimes we lose sight of that. And that then we should be there to support the person in managing that risk as best we can. But I've learned more from patients saying to me, Seamus, I prefer to fall in my own home than to be in a clean ward in a big institution. And there was one woman who said to me, she said, please do not cage me in an institution. And I said, that was an interesting word, cage. She was brought up in a mother and baby home. And she was saying, please, I've lived my early part of my life. I don't want to die in an institution. And that's about, again, attuning ourselves to the person, the adult, and what it is they want to manage and why.
I think Mary Donnelly will have the correct reference, but was Baroness Hale, Mary, said that a gilded cage is still a cage, famous British case. There have been questions, and this is obviously occurring in the context of COVID, and I see a question about residents being isolated within their room, which is something we probably did very badly at the start of the pandemic and weren't sufficiently respectful. Does anybody want to comment on that, about the issue of restriction and isolation and the impact on people and how we balance that against the need to respect preferences? Mary? You're mute.
No, Mary, somebody else?
No, you're great.
Yeah, okay. Yes, I think I think this is a real issue, and this is something that we haven't been good at, and we have to look at the distress for the individual very often, and the distress perhaps for the family member. And we have to look at innovative ways and use the least restrictive practices as we can. But certainly within ID services, and Caroline has spoken a little bit about that, people were creative, and they did try to use innovative approaches, whether it was through technology, whether it was if somebody was simply so distressed that they were absolutely in a really bad distressed place, you've got to understand and respect and do something about that. And we just can't hide behind the guideline to say, oh, well, that's the guideline and that's what the person is. I think we have to take a responsibility. We have to use the like of the ethical framework that Caroline talked about, and we've got to understand how can we make this bearable for the person.
I think, in fairness, the guidelines have improved and are more respectful of it in later situations. Interpretation of it by staff.
Yeah.
Can I ask?
Yeah, it's important.
Can I come back to Joanne, because that case study was very powerful, Joanne. And the question was, how did advocacy services become involved? And maybe a comment on the need, perhaps, for staff to be aware of the importance of it, and that we should be more proactive, perhaps. What do you think?
Yeah, so I suppose that to answer the query as to how it came to the advocacy service, it was a social care worker who had worked with Sue in the placement where she had lived for over a decade, who was concerned with the emergency move and recognised the potential need for advocacy. So that's how it came to the advocacy service. And I suppose it does point to the extra importance for those who may find it more difficult to reach advocacy services, to connect with advocacy services themselves. They're hugely reliant on those around them to support them to have that connection to independent advocacy. And again, it's about trying to break information down and make sure that people have choice as to whether or not they wish to engage with advocacy. We often receive inquiries to the service, and our first question is always, well, is the person aware that this inquiry is being made, and do they want an advocate? And that's often a step that is skipped in the process, and we will always refer the person back to, well, you need to have a conversation with the person, go through information with them. And again, there can be assumptions that it's okay to skip those steps because somebody's understanding needs additional support, accessible information, that it's okay to somehow skip that consent piece, and it's not. But yes, people absolutely need to be regularly reminded and provided with accessible resources to know what their additional support avenues are when issues arise.
In my view, it was helpful in the very complex Supreme Court judgment in AC that it did support the idea of the person's voice being heard. And that was in the context of wardship, and very much saw a role there for independent advocacy, and maybe that would be a push to us all to use it with greater vigour. A number of questions have come up, and I just want to mention them very briefly, and it is regard consenting for people, and just a reminder and to look at the previous webinars which have dealt with this in more detail, that nobody can consent on behalf of somebody who can't consent for themselves unless they have specific legal authority to do so, which is widely misunderstood, that others can sign forms, etc. In terms of formal decision-making tools for capacity, maybe again you, Caroline, do you think formal tools are helpful, or is it simply a matter of applying good practice?
Yeah, I mean, if it's a tool for, I saw a query come in around tools for recording. I suppose it's yeah, you might need to have some forms, but it's more around the process itself, I think, and applying those good practice principles to ensure the process of consent and decision making is appropriate and rights based. How you actually record it, forms that are required, I think, will vary hugely from person to person, whether it's written, easy read, video, objects. You just don't know. But if you actually follow the principles that we've discussed over the last few webinars to ensure that the rights-based approach is being followed, then hopefully the documentation will ensue along the same lines.
Yeah, I think there isn't ever going to be one tool, I think, that fits all. I do want to come back once more onto the issue of long-term care and involuntary choice, and a number of questions still raising it. The idea that it's better to die happily rather than live miserably is important. Seamus, again, back to acute hospitals where we all understand the pressures on beds, but nevertheless there is a focus on getting people out, isn't there? Particularly even during the pandemic at the moment. Do you think it's something we should have a separate webinar on, perhaps?
Absolutely. That, again, like with the acute hospital and the pressures that the acute hospital is under, the length of stay is such a big factor. And at times, like significant issues in relation to whether a person can go home or considering long-term care. Lucky enough in Mayo, we have some of the district hospitals in the past that would give us that little bit of extra time to work with the patients, and particularly some of the geriatricians would visit the district hospitals so that it wasn't a rushed decision. My worry after 20 years in the acute hospital is that some people are put on conveyor belts into long-term care. And again, Professor O'Malley, who you know, Professor Keith, he would always say, never make that decision, or don't allow that decision to be made in the acute hospital in relation to a person's life. But sometimes we have to, but it is a very big decision. But sometimes I think again, and I think it's an ageist piece. Oh well, you know, she's 95. What do you expect? I mean, the person has the right to choose where they want to live and where they want to die. And again, I think we have to be strong advocates, every one of us, to protect that right. Yeah.
I'm looking at the questions, a lot of them really are comments and comments of frustration at how badly some of this stuff is done and we should be doing it better. I'm going to draw this to a close. It's been an enormously helpful session. I think we're all clear on the direction we should be travelling. It's actually doing it in practice. But I think we've learned an awful lot from the panellists today on how we can do it better. And I'm grateful to all of you, to Caroline, Mary, Seamus and Joanne. Thank you very much. We will try and come back to any of the questions. As people were saying at the outset, a lot of them are recurrent, and we're looking at trying to draw frequently asked questions to give guidance outside of the webinar and to draw on the very useful points made by everybody. So thank you once more for your attention, and thank you to Quiva and Mary and Jackie for organising this so well. And until the next webinar, thank you. Goodbye.